has to be done for that. Frailty. So this is a reduced physiological reserve in multiple organ systems, which results in increase the inability to face physiological stress, and it is prevalent with increase in the age. So as age advances, all the organ systems start losing their reserve capacity. That is, for example, when you are young, when you are in your 30s and 20s and 40s, if you want to climb flight of stairs, you may do it in one shot. But as the age advances, that person will not be able to climb that same steps which he has achieved in one go. When he was young, he has to stop multiple times before he reaches the destination. So that was how the reserve goes down as the patient's age advances. So in medical patients, the frailty is associated with increased risk of mechanical fall, repeated hospitalization, worsening mobility, that is, they become more and more confined to one place, inability to perform activities of daily living. This particular terminology has to be included in your answer. So even doing your daily routines like taking a bath, dressing up yourself, going to the dining table and eating, all these are going to the toilet on your own. All these things are considered as activities of daily living. And even that may not be possible even in the absence of any diseases. As the age advances, the whole body is weak, and even continuing with your activities of daily living is very much reduced. And the nursing home admissions and death also happen because of the frailty. So frailty is nothing but patients or people become more fragile. They are bound to break anytime. So that is the other way you can remember. The pathogenesis involves maladaptive responses to stress and in multiple physiological systems, which leads to loss of dynamic homeostasis. This is the pathogenesis. And the pathological process, what causes this is responsible, or there is a chronic inflammation and immune system activation leading to sarcopenia, that is the muscle mass and the muscle strength both decrease. And there are age-related changes to endocrine system, such as the decrease in sex hormones, higher levels of cortisol, and vitamin D deficiency. Nowadays, if you take a assessment of vitamin D, majority of the labs give a value insufficient. Okay, so this is also considered as a part of the pathological process. And the process interacts with the risk factors like genetic and epigenetic factors, environmental and lifestyle stressors, acute and chronic diseases, which all result in manifestation of frailty and the consequent adverse health outcomes to that. And there are two major concept models for frailty which have been proposed. The first one is what is called the phenotype model, described by Freud. What do you understand by this word phenotype?
Sir, genetic condition, sir.
No, what is the meaning of phenotype? Genetic condition, okay. Genetic is another. There are only two types. One is phenotype, another is genotype. Genotype is the changes in the genes, whereas phenotype is what you see externally. Okay, that is called the phenotype. So every individual has got a phenotype and a genotype. Genotype is what you see in the genetic nature of the patient. You have to do it under the chromosomal studies, then you can find the genotype. But phenotype is what is seen outside. For example, a person who is tall, who is having a fair skin, who is having a iris color in different. These are all called the phenotype exhibitions. Whereas if you want to identify the genotype, what is the type of chromosome he is having, you have to study that chromosomal thing in the microscope and find out. Okay, so the phenotype model describes the 5 features. These are all you can see outside. How he is walking, slowness, weakness, exhaustion, weight loss, and low physical activity. These are all seen by our eyes, with naked eyes itself. So that is called the phenotype model, which produces these 5 changes in the person. Then you call them as frail. And the patients who have none of these 5 features, they are called non-frail patients. Those who have 1 or 2 of these features are called pre-frail patients. And those who have 3 or more, they are all called frail patients. So they describe them into 3 categories. Non-frail. For example, a 75-year-old person, he is walking very briskly. He is not weak. He is able to lift weight, and he is able to climb steps easily, and he doesn't complain of tiredness after a difficult task, and he has been maintaining a good health and weight, and he has good physical activity. He is able to play tennis, or he is going to go and swim. If all these things are present in a 70-year-old person, then he is called non-frail person. On the contrary, his low physical activity is not able to do running or swimming or playing any games, and he is feeling a little exhausted, then you call him as pre-frail patient. Otherwise, he is walking briskly and he is quite strong enough. But when 3 things are there, or more of these 5 features are there, then you call that patient as frail patient. And another important model that they have developed by Rockwood et al. Is called the cumulative deficit model. And in that, what they say is, this aging is accumulation of deficits in your activities, and was multidimensional risk state quantified by the number of deficits rather than by the nature of the health problems. So what are all the deficits? It may be hearing loss, it may be vision loss, it may be joint pain loss, joint immobility. So like that, you calculate whatever deficit is present in that, and then say that patient is frail or non-frail. So an accumulation of multiple deficits results in increasing strain on the system, and this causes vulnerability for system collapse and system failure. So that is the second model. So first model is the 5-feature phenotype model. The second model is the deficit model. And the deficit considers from multiple domains, including comorbidities, medications, physical and cognitive impairment, psychological risk factors, and common geriatric syndromes. So the second model utilizes all these things to assess the frailty. And this is measured by totaling the number of deficits present in the individual divided by the total number of deficits which are measurable and measured and expressed as an index between 0 and 1. Now, if the frailty index represents a continuum, however, it can also be trichomatized. That is, you can classify them into 3 categories. So you call it as trichomatization, indicating low, intermediate, and high. The earlier model we saw, it is non-frail, pre-frail, and frail. Here they say low frail, intermediate frail, and high level of frailty. So based on the value, whether it is less than 0.25 or more, equal to 2.5 to 0.4 and more than 0.4. So if these are if the patient is 0, that means he is a fit person, he is not frail. But when the values increase, then you call them according to these 3 grades. Now, what are the assessment tools that you can use for the frailty? It's where your Edmonton Frail Scale will come, which is a 17-point scale validated for use by non-geriatricians as well to assess the frailty. Of course, we will not go into the details, you don't have that. The Get Up and Go test, which is a part of the Edmonton Frail system, has recently been shown to predict morbidity and mortality across surgical specialties. So this is a very important assessment that you can do to assess the mobility as well as the muscle strength, etc., where you ask the patient to sit in a chair and without armrest. Okay, if the patient is able to get up from the chair without any support or holding his hand and pressing it on the seat, then he's quite fit. But if he needs some support to get up, either by pressing his hands on the seat and then try to get up, and use a stopwatch and find out the time that he takes to achieve the erect posture from sitting posture. Then based on the duration, if he is able to achieve it in a very short time without any need for any support, that means he is a fit person. On the contrary, if he requires some support of his own or somebody else's help and takes more than the normal time, then he is considered as a frail patient. So this is used as a very objective test in assessing the frailty in these patients. And there are now smartphone apps which are available to assess this Edmonton Frail score, and it can be downloaded free, and it is available in all these languages, and it takes a total of only 5 minutes to perform in each patient. The optimal perioperative care in these patients include identification of frailty, a multi-system, multidisciplinary evaluation preoperatively, and discussion of treatment goals and expectations. So that is how you try to do that. Now this picture will tell you what are all the things that are happening. So frailty can result in functional decline, sarcopenia, inflammation, that is the patient have a chronic inflammation and immune changes, and that is called inflammaging, and medical comorbidities may aggravate these things like having a diabetes, ischemic heart disease, hypertension. All these things will compound this normal frailty that happens because of aging, and there may be cognitive decline and social vulnerability, and all these things will lead to increased incidence of complication. Unplanned intensive care admissions will increase. The hospital stay will increase when they come for any infection or treatment or surgery, and the increased rate of discharge to care from facility, that they cannot straight away go home. They may need some home care therapy, or they may need some medical support at home also, and increased mortality also can happen because of increased frailty. So this is a Venn diagram which includes all these things like physical frailty, loss of physiological reserve that will result in sarcopenia, and social frailty, which is lack of resource status, and cognitive frailty is considered as reduced cognitive reserve, and function impairment, inflammaging, systemic comorbidities, and behavioral confirmation. So all these things will also happen. Now coming to the next topic, eclampsia is a life-threatening complication of hypertensive disorders in pregnancy characterized by sudden onset of seizures, and it should not be having any underlying neurological causes. That is a very, very important definition for eclampsia. So patient should not be an already a known epileptic, or he should not be having a intracranial tumor which can be the cause of the seizure. So it is purely pregnancy related. Then only you can call it as eclampsia. But it need not be always preceded with a preeclamptic features. It may come as a de novo at any time of pregnancy, and the patient may suddenly throw a fit. So this condition can occur before, during, or after labor, with the highest risk in the first postpartum days. And while a preeclampsia marked by hypertension proteinuria often precedes eclampsia, it may also develop without prior warning signs. So this may occur de novo also. Now, what are the risk factors for eclampsia? History of hypertensive disorder of pregnancy, family history of preeclampsia, in vitro fertilization. Patients who undergo IVF, they have more chances of developing eclampsia. Comorbid conditions like diabetes, renal disease, or autoimmune diseases, maternal obesity, history of preterm birth less than 32 weeks of gestation, and low socioeconomic status, multifetal gestation, that is twins or triplet pregnancy, and maternal age either too young, less than 20 or older than 35, and interval of 10 or more years since previous birth. So long gap between pregnancies of more than 10 years are also, patients are also at the risk of eclampsia. Now what exactly is the pathophysiology happening is, this is still very unclear, but there are theories which gain support, like dysfunction of blood-brain barrier. This is the first cause that has been mentioned, and I think Dr. Damodaran, you didn't mention this word at all in your answer. And cerebral blood flow autoregulation seems similar to hypertensive encephalopathy. And this disruption of blood-brain barrier allows fluids and protein to enter brain tissue, which may stimulate the seizure attack. And another hypothesis is that elevated blood pressure from preeclampsia causes dysfunction of autoregulation of cerebral vasculature, which causes hypoperfusion and endothelial damage or edema of the brain, which may be the other reason for the patient to develop a seizure attack. Now, autoregulation dysfunction, what are the changes that it can cause are acute hypertension, increase in hydrostatic pressure, reduce cerebral vascular resistance, and potentially damage microvessels, ultimately leading to cerebral edema, which may ultimately end up as eclampsia with a seizure. And eclamptic seizures in women with severe hypertension indicate that this is not the only underlying cause. Other proposed mechanisms include impact of circulating factors in preeclampsia, such as vascular factors, oxidized low-density lipoprotein, which all exacerbate the blood-brain barrier dysfunction through oxidative stress and inflammation. And theories involving cerebral vasospasm and overregulation also have been proposed. So there are three different theories which have been described for the occurrence of eclamptic seizures. Now, history and physical findings, what we find in these patients, it may be preceded by hypertension, visual disturbance, severe headache, and epigastric pain. And common visual changes include blurring of vision, double vision or scotoma, flashes of light, and transient cortical blindness. And the differential diagnosis of eclampsia is posterior reversible encephalopathy syndrome. And of course, the other causes, medical causes of epilepsy or seizures, that also may be present in the patient which has not been detected by proper history taking or examination. But one of the things which will very much resemble eclampsia is the posterior reversible encephalopathy syndrome or PRES. So eclamptic seizures can occur before, during, and after delivery, and mainly during antepartum period also. It will be a generalized tonic-clonic seizures, and postpartum eclampsia, particularly late onset eclampsia, this is the other name for that, defined as a seizure occurring more than 48 hours after delivery. So that is the first time the patient may throw a fit also. It is before it has not happened in the intraoperative, preoperative phase or prepartum stage. This may happen in the postpartum time also. Now, what are the evaluations that you have to do with respect to patients with eclampsia or the eclampsia who have thrown a fit? As various aspects of maternal and fetal health due to the conditions which have a potential impact on multiple organs. So tests are performed to assess for indication of end organ dysfunction, including proteinuria, renal dysfunction, liver dysfunction, CNS symptoms, and pulmonary edema and thrombocytopenia. So you have to do a chest X-ray, obstetric ultrasound, EEG, computer tomography, MRI, cerebral angiography. After seizure stops, but if the patient is in seizure, first attempt, your aim should be to control that only. So because of the urgent nature of eclampsia, evaluation conducted alongside emergent therapeutic intervention. So you must first proceed with the control of seizure, then only think of all the investigations that are required. So management comes to medical emergency which requires immediate treatment to prevent mortality of the mother and also the fetus. So seizure control, prevention of recurrent convulsions is the first line of management. So initial supportive management, call for help, maternal positioning, lateral disc is very important to improve the flow to the placenta and fetus and also reduce the risk of aspiration. So this is a procedure that is done for two purposes. One is to improve the blood flow to the fetus and the placenta. Another is to reduce the risk of maternal aspiration. Then airway and oxygenation, maintain patent airway, preventing aspiration by suctioning whatever secretions are coming. Give supplemental oxygen 8 to 10 liters. Monitor oxygen saturation to detect hypoxia either due to aspiration or pulmonary edema. Insert a bite block to prevent injury to tongue or soft tissues. Then comes the seizure management. Magnesium sulfate 6 grams intravenous IV over 15 to 20 minutes, followed by 2 gram maintenance dose, mainly to prevent recurrent seizures. So contrary to what you said as 4 grams IV, the dose required when the patient is throwing a fit is 6 grams IV over a period of 15 to 20 minutes. In patients without IV access, patients who may be sometimes grossly edematous because of preeclampsia and they may suddenly throw a fit and come from home before any admission to the hospital. At the time they may not have a IV access and it may be difficult to get also if they have a generalized anasarca. So in such situation, a loading dose of 10 grams intramuscularly followed by a maintenance dose of 5 grams every 4 hours may be used as an alternate regimen. And patients with contraindications to magnesium sulfate like myasthenia gravis, hypocalcemia, renal failure, cardiac ischemia, heart block or myocarditis, alternative seizure therapy like phenytoin and diazepam may be considered. That is the alternative that you have to keep in mind. And levetiracetam may be preferable in patients with myasthenia gravis because this condition may be exaggerated by phenytoin. So if patient has any previous history of myasthenia, then go for this drug rather than going for phenytoin. Now convulsions, if they recur, consider adding 2 to 4 grams of magnesium sulfate again over 5 minutes. And if seizure persists after 20 minutes or more than 2 seizures have happened despite magnesium therapy, then you have to give another dose between 3 to 5 minutes is recommended. Other alternative drug is sodium amobarbital 250 milligram IV in 3 minutes or diazepam loading dose 10 milligram IV over 2 minutes, then maintenance dose 40 milligram in 500 ml normal saline for 24 hours, followed by 20 milligram in 500 ml for the next 24 hours. Phenytoin loading dose 10 milligram per kg or in first 30 minutes, then 2 hours later administer 5 milligram per kg over 10 minutes, followed by maintenance dose of 300 milligram IV over 10 minutes for 24 hours from the last seizure. And magnesium sulfate serum level monitoring is important to avoid toxicity due to overdoses because when the patient is throwing a fit, it is high dose we give that itself can cause magnesium toxicity. And fetal monitoring is vital to assess the viability and safety of the fetus. And antihypertensive measurement is by gradually reduce the blood pressure. Do not bring it down suddenly from a very high level and maintain it between systolic of 140 to 160 and diastolic 90 to 110 without causing a sudden drop that may compromise placental perfusion. So for that you can use hydralazine 5 to 10 milligram IV repeated every 20 minutes with a maximum dose of 20 milligram. And labetalol can give 10 to 20 IV followed by 20 to 80 milligram every 10 to 30 minutes with a maximum dose of 300 milligram or an infusion of 1 to 2 milligram per minute IV. And nifedipine, oral nifedipine, if the patient has become conscious in between, you can give 10 to 20 milligram repeated every 20 minutes. And the subsequent dose of 10 to 20 milligram administered every 2 to 6 hours. And the maximum daily dose in a 24 hours, you can use up to 180 milligram when the patient is tolerating oral intake. After the seizure control, monitor oxygen saturation, vital signs, urine output, fluid status closely for at least 72 hours. Now coming to delivery considerations in a eclamptic patient, maternal resuscitation is the first one. Maternal and mother should be stabilized before proceeding with delivery. And delivery timing, eclampsia is an indication for early delivery. Cesarean delivery is not always required. So mode of delivery should be based on various clinical features like gestational age of the fetus, fetal presentation, whether it is vertex or breech, cervical favorability. These 3 points can be taken into consideration. Antenatal steroids have to be given if the pregnancy is less than 34 weeks of gestation to allow fetal lung maturity. And delivery should be delayed to complete the steroid, should not be delayed to complete the steroid course if maternal fetal condition begins to deteriorate. Now, transfer and tertiary care. When will you have to manage this? Patients with severe eclampsia should be managed in the facility with the intensive care and neonatal care units, particularly for those in early pregnancy. Blood pressure and seizure should be controlled before transfer of the patient. Ambulance transfer, the patient should be done with appropriate medical personnel in fetal monitoring to manage any recurrent seizure during transit. So the ambulance should have all the facilities. The complications that can set in because of this eclampsia are placental abrasion, or it may be part of HELLP syndrome. DIC may have pulmonary edema, aspiration pneumonia, cardiopulmonary arrest, acute renal failure, and venous thromboembolism. These are all the complications of eclampsia. Now, anesthesia for eclampsia patients for operative delivery. After seizure control, GCS scoring should be assessed, BP control should be achieved, fetal condition should be assessed, and coagulopathy should be evaluated. So GA is considered unsafe because of potential problems like difficult airway, exaggerated hypertensive response to laryngoscopy and intubation, risk of aspiration pneumonia, drug interaction, etc. That is because of the large dose of muscle relaxant. But GA is preferred choice in participants who have coagulopathy, who cannot be administered regional, or who have already developed a pulmonary edema, or patients with who have thrown a fit and are having a GCS of less than 9 and are unconscious with a GCS of less than 9. These are the 3 categories of people who have to be given GA. Coagulopathy, already formed pulmonary edema, or a fit with GCS less than 9. Regional anesthesia is a safe option for the avoiding the big pitfalls of GA, and it is only risk that is feared about is the severe hypotension that may happen after a single short spinal. So this fear is unwanted as these patients have high levels of circulating catecholamines, which may protect them against a sudden acute fall in BP. So the risk of development of epidural or spinal hematoma because of thrombocytopenia is also there. So that is the reason why we have to assess the coagulation effectively. And the safe platelet count in these patients is supposed to be 75,000 to 80,000 microliters. And normal from partial thromboplastin in time and prothrombin time indicate that you can safely go ahead with regional. And post-operative care, convulsions and pulmonary complications occur in the post-operative period. So laryngeal edema may worsen, re-intubation if you have given GA and intubated the patient, antihypertensive therapy and the anticonvulsant medication maintained for as long as the patient remains symptomatic. Invasive monitoring, if used intraoperatively, should continue in the postoperative period. And adequate postoperative analgesia, meticulous fluid balance, and vigilant monitoring are very, very essential. I think that is the answer for eclampsia. Okay.